Good morning to everybody and welcome to UAB Pathology Grand Rounds. It's good to see so many of you as you continue logging in. Today, it's my pleasure to introduce Dr. Zarjou. He's an MD PhD assistant professor in the Department of Medicine here at UAB in the Division of Nephrology. Dr. Zarjou originally received his medical training from the University of Debrecen in Hungary. And then in 2011 was actually when we first got him here in Birmingham at UAB, where he completed both his clinical fellowship and then decided one doctorate wasn't enough and got his PhD here as well. We were then fortunate enough to retain him after his thesis work, where he joined the faculty starting back as an assistant professor in 2017. Although only faculty for this 3 to 4 years, he's been very proliferate. He's been very successful in his dual hat of physician scientist. He's done a lot of work on iron metabolism and the ferritin system, particularly in the context of kidney disease. And it's this that we'll hear him talking about today. He has over 35 manuscripts and book chapters in these areas. And he's currently supported by both an NIH K08 award, as well as an SSCI Scholar Award. He's been recognized not only here at UAB, but also nationally and regionally, winning multiple awards, including those from the Southern Society of Clinical Investigations, National Kidney Foundation, and the American Society of Clinical Investigation, particularly receiving the Young Physician Scientist Award. So with that, I will not take any more of Dr. Zarjou's time. Please, I'm looking forward to hearing what you have to say. Thank you, Dr. Zarjou.
Thank you, Adam. That was a very kind introduction. I just wanted to add that I spent an additional 2 years in Dr. Agarwal's lab as a postdoc. So I've been in Birmingham since 2008, actually. So been here for a long time. Thank you, everybody, for joining. Good morning, everyone. I'm going to share my screen and get started. So as you can see from the title, I'll be speaking about lymphangiogenesis in the context of kidney disease. Now, the very first mention and discovery of a second vascular system goes back to the ancient Greeks. So it was recognized that we do have a second vascular system even back then. But then it wasn't until Gasparo Aselli in the early 1600s that described milky veins in the gut of a well-fed dog that we heard again about the lymphatics. Nevertheless, the progress in studying the context of lymphangiogenesis, its instigation and propagation, development, and its importance in various aspects of health and disease was really mitigated because of the difficulty distinguishing between blood and lymph vessels. So as you can see here, something remarkable happened in the late 1990s where several seminal, almost back-to-back papers discovered multiple markers that are either exclusively or at least predominantly expressed by lymphatic endothelial cells. So as you can see, this led to a great interest and a significant increase in the number of publications that are related to lymphangiogenesis. So as you can imagine, the number of markers for lymphatic vessels continues to grow, and there are numerous markers that have been proposed to be lymphatic markers, either exclusively or at least predominantly. However, a deep search within the literature suggests that there are really 4 markers that are relevant to this area. The very first one is really exclusive to the lymphatics. It's the VEGF receptor 3, or FLT4 is the other name. And it responds to the ligands of VEGF-C and VEGF-D. Sorry. And then there is podoplanin and LIVE1, but I also want to touch on PROX1. PROX1 is a transcription factor that is crucial in development of lymphatic endothelial cells. The same story applies to the ligands, growth factors, and mediators that induce lymphangiogenesis. There is a bunch of them. But again, the VEGF-C and VEGF-D have been the most studied growth factors and mediators, and they're the most relevant when you do a literature search regarding lymphangiogenesis. Now, the structure of lymphatics is rather different from blood vessels. Here in this cartoon, you can see some of those differences. And perhaps the most striking difference is lack of a complete basement membrane. And this allows for transport of fluid, proteins, lipids, of course, and lymphocytes in and out of the lymphatic vessels. On the other hand, if you consider the fact that there is no basement membrane here that is intact, the vessels obviously become prone to collapse. But these tiny microfibrillar structures prevent such collapse, and they give stability to lymphatic vessels. Another feature of the lymphatics that's distinct from the blood vessels is the presence of these valves that ensure that there is unidirectional flow of the lymph. And you can appreciate that in this lymphatic vessel as well, where obviously blood vessels do not contain any valves. Now, from a molecular perspective, we all know that the angiogenesis is really modulated by two main receptors, the VEGFR1 and VEGFR2, and the number of VEGFs have now grown to from VEGF-A to VEGF-E. On the other hand, if you notice here, it's really the VEGF-C and VEGF-D through their actions by activating the VEGFR3 or FLT4 that induce lymphangiogenesis. It must be noted, though, that the VEGF-C at very, very high levels can induce some angiogenesis. So at physiological levels, it's only implicated in the context of lymphangiogenesis, but at very high levels, it has some action on inducing angiogenesis as well. So what's the relevance, and why should we care about lymphatics in health and disease? Well, it's important to note that about 20% of the interstitial fluid is actually reabsorbed into the lymphatics. Therefore, lymphatics are very important in the context of fluid homeostasis. Obviously, they're involved in immune surveillance, resolution or exacerbation of inflammation and wound healing. Clearly, their milky appearance is because of fatty acid absorption. And it's been shown that absence of lymphatic vessels is actually incompatible with life. Furthermore, patients with dysfunctional lymphatic vessels suffer from chronic edema and impaired immune responses. So the next question that comes to mind is, how are the lymphatics involved in inflammation and injury models? Well, one could argue that lymphatics are important and beneficial because they take part in clearing the debris, removal of pro-inflammatory cytokines, migration of regulatory T cells, and drainage of excess fluid. Therefore, you could argue that yes, induction of lymphangiogenesis is actually a beneficial and adaptive response, and there is evidence for that. And the literature suggests that induction of lymphangiogenesis is actually beneficial in various models of injury, including myocardial infarction, polycystic kidney disease, and lung transplantation. In contrast, one could also argue that lymphangiogenesis could worsen outcomes by increasing the migration of leukocytes to the site of injury, enhancing the exacerbation of inflammation by antigen presentation, and maintaining a microenvironment that's filled with cytokines. Hence, one could argue also that lymphangiogenesis could be detrimental. In fact, evidence suggests that in the context of renal and corneal transplantation, as well as diabetes and obviously tumor metastasis, increasing lymphatics could have detrimental consequences and it should be considered a maladaptive response. So being a kidney person, obviously we're interested about how lymphatics are involved in kidney physiology as well as pathology. But to begin with, I just want to give you an idea about how the lymphatics actually insert into the kidney. One should think of lymphatics as a parallel pathway compared to the blood vessels. As you can see in this cartoon, they actually wrap themselves around every blood vessel that enters the parenchyma, and as they branch off along with the blood vessels, their numbers and their diameter actually decreases. However, it's been noted that the Bowman capsule does have plenty of lymphatics that's actually unique to the kidneys. Now, there is also evidence that irrespective of the mode of chronic kidney disease, there is plenty of lymphatics around in the biopsies of patients. Here you can see some of those examples. Here you can see a healthy kidney, a minimal change disease, lupus nephritis, IgA nephropathy, tubular interstitial nephritis, as well as obstructive nephropathy. So irrespective, you can see that there is significant amount of new lymphatics compared to the healthy kidneys. And you can also see that the kidney itself, especially the tubules here, are positive for the ligands that are involved in instigation of lymphangiogenesis, namely VEGF-C, VEGF-D, and in this case, in this manuscript, FGF2 was also studied. Now, as I mentioned, polycystic kidney disease has been one of the rare conditions in the kidney realm that's been studied in the context of lymphangiogenesis. Here, Huang and colleagues in a nice JSON paper used a PKD model, polycystic kidney disease model, and started injecting these mice at day 7 post-birth for 14 days with IP injections of recombinant VEGF-C or vehicle. And they confirmed that indeed the VEGFR3 was activated and the VEGF-C was not degraded upon administration. What was striking was the decrease in size of these kidneys following administration of VEGF-C. You can see that a polycystic kidney is much larger compared to the one that received VEGF-C for 14 days. And here you can see the quantification of that was significant. And not only the kidney size, obviously the size of the cysts were much smaller, and that was also significant. And perhaps more importantly, it was the plasma creatinine in this case that they measured that suggested that there was a beneficial effect in terms of better renal function. Now, unfortunately, there isn't a lot more in regards to the kidney in the literature. Here, to the best of our knowledge, these were the only 4 manuscripts that we found that had relationship between lymphangiogenesis and kidney disease. Now, the unfortunate thing about all 4 of these manuscripts is that they used a unilateral urethral obstruction model. Now, for those of you who are not familiar with UUO, basically it's a surgical manipulation where you ligate one of the ureters, and as expected, that leads to a significant hydronephrosis. Now, we argued and we reasoned that perhaps this is not the best model to study lymphangiogenesis. And that stems from the fact that there is plenty of interstitial fluid that is building up in the kidneys. And as I mentioned, the lymphatics are very important in terms of reabsorbing fluid from the interstitium. Therefore, it becomes a little bit of a confounding factor here, whether or not it's the inflammation, it's the injury to the tubules, or it's a mere induction of lymphangiogenesis secondary to the increase of interstitial fluids that's increasing the lymphangiogenesis. So based on these observations, we came up with some very simple questions at first. And the questions were as follows. Does lymphangiogenesis occur as a result of acute kidney injury? and where are the ligands of lymphangiogenesis expressed during injury, and what are the dynamics of these ligands following acute kidney injury. So the very first set of experiments that we did were related to ischemia reperfusion. We performed a bilateral ischemia reperfusion for 20 minutes on black 6 mice, and we performed function analysis as well as analysis of lymphangiogenic response on days 1, 3, 7, 14, and 28. Now, as expected, the serum creatinine was markedly elevated on day 1, and this elevation kind of diminished as time passed, and the creatinine levels were almost back to normal by day 28. However, as we know now, the kidneys did not forget the injury, and obviously there was plenty of fibrosis going on, and this is depicted here by Picrioceras stain on different days that stains collagen in red. Next, we looked at the ligands of lymphangiogenesis from whole kidney tissues at the RNA level. Here you can see that the VEGF-D slowly increases in terms of RNA and transcription level. The VEGF-D was mainly significant on day 3. However, when we looked at different markers of lymphangiogenesis, including VEGFR3, LIVE1, podoplanin, and PROX1, we noted that although there were significant differences on various days, such difference was really depicted as a variable context. You can see that there are multiple different points here, and we attributed this variability to using the whole tissue lysates and the fact that the lymphatics are pretty scattered around. We also performed Western blot analysis, and here you see the densitometry results. And again, confirmed that yes, the VEGFR3 was significantly upregulated, mainly on days 3 and 7, and so was the transcription factor on days 3, 7, and 14. But we were also surprised to see that the levels of VEGF-D started to decrease on day 14 and 28. And such decrement was really visible and conspicuous in regards to the VEGF-C. So here we reason that the decrease that we are seeing in these Western blots may be related to the fact that the ligands are being secreted, and hence the parenchyma itself is deficient in terms of these ligands at this point. So to prove this hypothesis, we looked at the serum of these mice and we performed ELISA assays. And again, you can see that both in the serum, both VEGF-C and VEGF-D were elevated on different time points in the serum. And perhaps more importantly, in the urine of these mice, when you normalize for creatinine, you note that there is a significant increase in the amount of VEGF-C in the urine as well as VEGF-D following injury. So we were also interested to see how the kidneys respond in terms of expression and secretion of these ligands. So here you see an immunofluorescence stain, and what's really jumping out on the first glance is the fact that the VEGF-C was really in a homogeneous way expressed by many, many tubules across the kidney at baseline. The same was applicable to the VEGF-D expression, but you know that this expression pattern significantly differs on day 1. Perhaps the striking difference is the fact that now you have this basolateral stain that is suggestive of these ligands being transported out of the tubules and into the interstitium. I just want to point out here that these are really casts, and the staining here based on our negative controls is just background casts. So the fact that you see these red casts within the tubules is not reflective of the VEGF-D itself. Now, nevertheless, the kidneys really never went back to their homogeneous pattern of expression of VEGF-C or VEGF-D. Such expression remained patchy and heterogeneous for both of these ligands throughout the study period of these mice. next, we investigated the number of lymphatics that were available on different days following injury. Here we stained with VEGFR3, rather specific for the lymphatic vessels, and you can see the nice lumens in these lymphatic vessels on different days that are depicted here in this panel. We also performed quantification of these lymphatic vessels, and as you can see, they reach significant numbers on day 7, 14, and they persist on day 28 as well. So next, we asked a simple question, and as you know, the mechanical injury is associated with the ischemia or perfusion, because basically what you're doing is you're clamping the renal pedicle here for the 20 minutes of ischemia that we used here. So we asked whether or not such mechanical injury to the lymphatics at the time of ischemia may be the instigating factor that is leading to the induction of lymphangiogenesis that we saw in our model. So to circumvent this issue and this challenge, we used another model of acute kidney injury. Here, we took advantage of cisplatin. As you're well aware, cisplatin is still widely used and very efficient in terms of a chemotherapeutic agent. However, it does bear nephrotoxicity side effects. Here we used a commonly used dosage, 20 mg per kg to induce acute kidney injury, and mice were sacrificed on day 3 and tissues and serum were analyzed. And we also use a repeated low dose to induce CKD, and this is also commonly used in the literature now. Here we used 9 mg per kg on day 0, 7, 14, and 21, and then mice were sacrificed on day 28 and tissues were analyzed. So although not as conspicuous as the ischemia or perfusion model, again, we saw a similar pattern. You can see here, especially with VEGF-C, that the pattern of expression goes from an entire tubule type of expression, mainly to a basolateral pattern, and that patchy expression pattern persists even with high dose and repeated low dose cisplatin model. Again, we noted that the amount of VEGF-C and VEGF-D was higher in the serum, suggesting that these ligands are increased in the serum, and therefore they may actually have distant effects as well. And again, in the urine of these mice, we found increased levels of both VEGF-C and VEGF-D, although the VEGF-D was mainly significant with the high-dose cisplatin model compared to the repeated low-dose and the CKD model. And we also measured the number of lymphatics in both models. The high dose and repeated low dose both showed us that there is a pattern of increase in the number of these lymphatics, and the number was significant for the CKD model compared to the acute model. So next, we also took advantage of another model of acute kidney injury. These mice were generated by Zhang and Dr. Harris at Vanderbilt. So basically, this model of AKI is based on the fact that a diphtheria toxin receptor is inserted into the proximal tubules, and then following administration of diphtheria toxin, you see a significant rise in serum BUN and creatinine within few days of administration. Therefore, here we're dealing with a model of acute kidney injury that only affects the proximal tubular cells. Nevertheless, despite the mere injury to the proximal tubular cells, you still see a similar pattern where the basolateral stain of the VEGF-C is very prominent, and the patchy nature of the VEGF-D is also being exhibited. And furthermore, we found that even in this model, the number of lymphatics increases following injury. So our next question was regarding the sources of such lymphangiogenic VEGF ligands. So to investigate this, we cultured primary cells from proximal tubular cells, as well as bone marrow-derived macrophages. What's really evident here is the fact that although the proximal tubular cells express both VEGF-C and VEGF-D, the macrophages only express VEGF-C. This was confirmed by immunofluorescence as well. Here you can see kidneys where macrophages are scattered around, and you can see that bright, intense stain in the cytoplasm. And also in the red polyp of a spleen at baseline, you can see multiple of these macrophages. And here you can see a higher magnification where the cytoplasm is really intense for VEGF-C. However, there is no VEGF-D expression. So to summarize our findings so far, I hope I was able to convince you that irrespective of the nature of insult, lymphangiogenesis is rapidly and robustly induced. And we showed you that the VEGF-C and VEGF-D are abundantly present in tubules at baseline, and their expression pattern is significantly altered following injury. Importantly, both of these ligands increase in serum and urine post-injury, and this suggests a potential novel urinary biomarker of AKI, as well as progression of kidney disease. Now, we also showed you that both macrophages and tubular cells produce and secrete VEGF-C. However, VEGF-D is only produced by the tubular cells, and macrophages do not express this protein. I guess the more important and relevant question is, what is the importance of lymphangiogenesis in the context of disease and kidney function, and whether or not this is an adaptive response following injury? So to answer this question, we actually performed some cisplatin nephrotoxicity models, and we used a chemical called MAZE51 that is an inhibitor of VEGFR3. So basically, we inhibited lymphangiogenesis by using MAZE51. And as you can see here, the serum creatinines were significantly higher in the absence of lymphangiogenesis following administration of cisplatin. We also performed GFR measurement using FTSE conjugated sinistrin. And again, you can see that the GFRs were markedly lower when you inhibit lymphangiogenesis. And we also looked at a biomarker of kidney injury, namely kidney injury molecule 1, and this was also significantly higher. So we reasoned that perhaps there is more inflammation going on. And in this context, you can see that if you inhibit lymphangiogenesis, there is a lot more phosphorylated P65 and therefore NF-kappa B activation. And there is also more IL-6 production in these kidneys, both of which were significant based on our densitometry results. Now, we were also interested in another mouse model that was produced by one of our collaborators in Houston, namely Dr. Rutkowski. So basically what he did was he generated kidney-specific VEGF-D overexpressors, and you can see the results of that here. This is a VEGFR3 stain, and you can see the marked increase in the amount of lymphatics in the kidneys of these mice. Now, he was interested in hypertension, so I'm not going to go into details of that, but basically lymphangiogenesis was beneficial in hypertension, but we took advantage of these mice. What we did was we received the mice at 10 to 12 weeks of age. Now the promoter of VEGF-D is under the control of doxycycline. We administered doxycycline for 3 weeks. On day 0, following the 3-week administration of doxycycline, we performed ischemia perfusion and performed some analysis on days 1 and 7. And here is a corroboration that indeed the VEGF-D was significantly higher after doxycycline administration. And here you see the results of flow cytometry on these kidneys, and the rest of the studies are pending right now. Perhaps the most striking was the amount of T cells per kidney, which is rather not surprising in hindsight. But you can see that even under sham conditions, there were a lot more T cells in these kidneys, and that persisted on day 1 as well. And further gating and analysis suggested that these T cells are mainly CD4 helper T cells that are present in the kidneys. And as I mentioned, the functional analysis studies are still ongoing, but we also confirmed the presence and induction of lymphangiogenesis in the kidney. Here I'm going to show you a video where we took advantage of Prox tomato mice, where the Prox cells are going to stain as red, and we stain everything else with F-actin. So basically, whatever you see as red is lymphatic vessels or cells that are becoming lymphatic endothelial cells. But note that this kidney right now is at baseline and quiescent state. So I guess the take-home message from this video is that the number of lymphatics at baseline is not really paramount here, and they're scant and scattered around, and they follow the pattern of insertion of blood vessels. However, in the next slide, here is a kidney that has undergone ischemia or perfusion. And what I would like you to notice is the increase in the number of cells that are developing into lymphatic endothelial cells. Hence, there is a lot more red cells around the kidney. Now, as I mentioned earlier, the PROX1 is a transcription factor. Therefore, it may not give justice to the number of lymphatics and their structure. So we also stain these kidneys at baseline with LIVE1, which is another model of, another marker of lymphatics. And I guess the take-home message of this video is just to see how the lymphatics wrap themselves around the blood vessels as they enter the kidney. So I hope I could give you some of the work in progress that's going on in Dr. Agarwal's lab and some of the work that I've been involved with. Really, the field of lymphatics is expanding as we speak. And perhaps one of the most important aspects of lymphatics also attributes to the kidney transplant patients. We do have some preliminary data on that as well. However, I think I'm going to end it here by thanking my mentor and really my role model, Dr. Agarwal, and Dr. Black, who's been instrumental in helping with many of these figures and studies that I just presented to you. Also, some of the lab members, Amy Traylor, Stephanie, Esmond, Yanling, and Jenkin, and also our collaborators, Dr. Tarek El-Chakir, Dr. Harris, Zhejiang, and Dr. Rutkowski, and of course our funding sources. So I'll stop right there, and thank you so much for your kind attention. I'll be happy to answer any questions you may have at this point. Thank you.
Thank you so much for that. Definitely an area of science that I had not truly appreciated. You definitely presented in a compelling way. We're now open for questions. Please just unmute yourself and turn on your camera if you're comfortable to ask. I'll start. Earlier on in the presentation, you had a figure with a temporal expression. I think it was VEGF-D and C with a transcription factor. And there appeared to be a marked decrease in C prior to D, is that correct?
Yes.
But then it seemed to rebound a little. Do you think there's both post-transcriptional and post-translational regulation going on of that, or is it all at the, because you showed the transcription factor, but that little dip and return was interesting to me.
So that's an excellent question. And let me go back. And very good observation. Yes, the PROX1 levels actually decreased. This was a little bit surprising to us, but it turns out that a similar pattern was observed in here is a Nature paper that looked at cardiac lymphatics, and the PROX1 following myocardial infarction actually goes down for a few days, and as you mentioned, it rebounds. So the idea is that there is plenty of PROX1 RNA around, and what happens is following injury, so the cells are ready in case something happens, the RNA is available, and it's the translation of the RNA that actually leads to the decrement in terms of the copy number of the mRNA. So again, as you noted, at the protein level, the PROX1 is significantly up even on day 1, but really on day 3 and day 7. But the RNA level, it goes down. You're absolutely right.
Okay, that's interesting. I know on your CV, you also have iron background. It's kind of reminiscent of how iron sensors work, right?
You're absolutely right. Okay. Yes, the ferritin, what's really remarkable about my molecule of interest, ferritin, if you compare the ferritin to a GAP-DH level, you see about 100-fold higher levels of RNA compared to GAP-DH. And that's why if you have an injury model, you may not see much difference in terms of the RNA, or perhaps a slight decrement following injury, but it's really the protein that gets translated really rapidly, and you can capture that with Western blot. You're absolutely right.
Interesting. Cool. Looks like we have another question.
There is one in the chat, but I was going to ask something also. Thank you very much for your presentation. One of the things that I noticed in the polycystic kidney disease model, after treatment, the number of cysts seems to reduce, but the cysts are epithelial. So what's the relationship? How do you explain that? That there is a reduction on the epithelial cysts despite the fact that you're using like VEGF? So,
you know, obviously I can only relate to what was stated in the discussion part of that manuscript, because we were not part of the group who performed those studies, but their rationale was that increasing the lymphatics results in improved fluid homeostasis and removal of extracellular fluid, and hence the pressure on the cyst significantly decreases. That may result in reduction of the size of the cyst, and hence reduction in the size of the kidney. Now, whether or not this is accurate, I cannot vouch for that, but obviously it takes a lot of experiments to really pinpoint what is the exact reason behind it. And most of what they described in that paper was observational studies. And given the novel nature of those findings, I think it passed under the radar. But you're right. And although the rationale makes sense, there may be other mechanisms that still need to be unraveled. But again, that's a very good observation, excellent questions. And unfortunately, I don't have anything else other than what they stated in their discussion.
Thank you very much.
Sure.
Dr. Alexander left a question in the chat, but then it looks like he had to leave. He asked if you've had an opportunity to study any patients with lymphangiomyopatosis.
I have not. And, you know, like I said, our lab, this was kind of a side project that had started to, you know, kind of blossom and increase interest in the lab. As you noted in the introduction, Dr. Agarwal and my lab are really interested in the heme and iron metabolism and their relationship to various forms of kidney disease. So that's an excellent question. And, you know, there are some evidence regarding the sirolimus that is commonly used in transplant patients and how it affects the lymphatics and the lymphocyte that's very commonly seen in some patients that receive transplant and sirolimus. So there are large lymph, I don't know the right term, but I think it's a benign tumor in the lungs. It would be an area of interest, perhaps, if we could collaborate with someone in the realm of pulmonary diseases, if we have some of those sections. And my knowledge regarding that is rather limited. So, you know, if I don't want to comment too much on something I don't have a lot of information on.
All right, thank you so much. Are there any other questions? Okay, well, it looks like we've made March Kidney Month, so please join me in thanking Dr. Zarjou for his presentation today, and please join us back next Thursday when we hear Dr. Agarwal tell us a little bit more about kidney disease. So thank you all for joining us, and please join me in thanking Dr. Zarjou one more time. Thank you again.
Thank you, everybody. Appreciate your attention and the opportunity.